Hi, welcome back for part two. So in the first part, I talked you through how I conducted a scoping literature review, moved on to a qualitative study, then a Q methodology study, and then a postal survey sent to men with rheumatoid arthritis. And this was to look at how widespread the impact and coping strategies are that we identified in the earlier phases. And in the postal survey, we found that at least 43% of men had severe disease, poor coping, and poor psychological status. So 43% of men were considered part of what was factor B in the previous Q methodology study. And we say at least 43% because we think that we're still under recruiting the men that belong to that group. That a higher proportion of men, so the majority of men from the survey study loaded onto factor B as opposed to factor A, and the remainder were between the two groups, which validates the idea that we were under recruiting those men in the Q methodology study, so the face-to-face study with a more qualitative element. We don't know the cause and effect. It could be that those with severe disease feel like they're not coping, and that causes poorer psychological status, or it could be that struggling to cope and having the poor psychological status impacts their disease. We do know that baseline and persistent symptoms of depression and anxiety are associated with poorer health outcomes and reduced treatment response. So we were interested as well in, if you want to know more about that study, it is published, so do feel free to read the full paper. So we were also interested in what men's support preferences were and whether these were different to those of women's. So we added an additional questionnaire in with the postal survey, and we sent this, as well as to the men, we sent this to around 100 women. So the men's top preferences were a website for information, which generally reflects usual care. This is available. A question and answer session with their consultant, an organised talk about research findings, education on symptom management, or a question and answer session with their specialist nurse. The Q&A with the consultant came from the focus groups. Say, for instance, every 2 months a consultant is in a room, there's maybe 20 people, could all discuss what's going on. And as did the organised talk about research findings. If I could have something coming the other way in relation to what research has been done, what the findings are, you're coming in and listening to that. So by contrast, women also prioritised a website as their top priority. But their second priority was a talk from lifestyle experts, for example, on diet. Again, they were interested in education on symptom management, talk about research, and they valued equally the Q&A with a consultant or specialist nurse. And it's worth noting that more women prioritised all of the options. So the highest ranked option for women was rated by 80% of women, whereas it was only 69% of men. So comparing the two groups of men, on the left, you've got the overall preferences for men that I've just talked through. And then in comparison to those in factor A, so the ones that were able to accept and adapt to their condition, compared with factor B, the ones that were struggling. Again, they both had the same top priority, but there was a significant difference in the ranking of education on symptom management at the second priority level for men in factor B. And splitting it like this, an organised talk from lifestyle experts also made it into those in factor A's preference. But it's worth noting that it's those in factor B that are struggling. So if we're thinking about developing an intervention, we should be prioritising the needs of those in factor B. In terms of practical issues, the majority preferred a group with no fixed commitment, but an advertised timetable they could dip in and out of. Rather than, for example, a 6-week intervention. The majority, again, had no preference for group gender, but this wasn't an overwhelming majority. And it's also worth noting that in the focus groups, when the men said they didn't mind if there were mixed groups, when I asked them if they would have opened up in the same way if there'd been women present, they tended to say no. So it's potentially worth providing some form of single-sex intervention, even if that's a small part of it rather than the whole thing. And some men were particularly opposed to group gender, to mixed gender groups, and this comes from the focus groups. Pardon me for saying this, they talk a lot and say nothing. Men can't get a word in. And although that's quite a jarring quote, it's worth remembering that when a condition affects more women than men, then men can often be outnumbered or the marginalised ones if they do attend support for that particular issue. So women were more likely to report the intention to attend all of the options than men. There was no particular preference, or the majority had no particular preference for group gender, but we do know from other groups, for example in obesity groups, male-only groups do differ to mixed gender groups in terms of level of engagement, the language that they use, and the level of success. Men preferred practical rather than emotional support, for example, a question and answer session, talks from research experts. And this validates the idea that men use information exchange as a form of emotional support. There were little differences between factor A and B, which supports the idea that we could provide one intervention for both groups. But in terms of commissioning, it may still be difficult, given only 30% of the RA population are men. It may be difficult to commission an intervention just for men with rheumatoid arthritis. So we thought we'd consider an intervention across multiple rheumatic diseases. So I'm currently working on men with systemic sclerosis. Systemic sclerosis, or scleroderma, is an autoimmune condition, a collagen vascular disorder. So it involves hardening of the arteries, hardening of the skin, lack of blood flow to extremities, causes difficulty in movement, it causes facial impact of the condition, so tightening and broken blood vessels. It can be limited, so mostly restricted to the extremities and is slowly developing, or it can be diffuse, which causes organ involvement. There's no cure. Around 50% have only a 5-year mortality, and there's been no change in that for the past 40 years. It's a rare condition, so it affects around 20 in a million, and the peak age of onset is 20 to 50 years. So we thought it was sufficiently different to rheumatoid arthritis to be of interest to see whether a shared intervention would work. So this is Dr. Mike Hughes. He's a rheumatology consultant from Sheffield. We actually met at a Arthritis Research UK Fellows Day, and he knew that I was focusing on men with rheumatoid arthritis. He's an expert in systemic sclerosis, so we thought that we'd work together, and we're both co-applicants on a successful grant to the World Scleroderma Foundation. So it really demonstrates the importance of networking throughout your PhD or postdoc, or throughout your interactions. So systemic sclerosis is again more common in women compared to men. Men have a more severe disease course, including significantly reduced survival rates than women. The pathogenesis may differ significantly between men and women, but little is known about the gender differences relating to psychosocial aspects, and no qualitative studies have previously explored the experiences or support needs of men with systemic sclerosis, despite the idea that men are dying faster than women with the condition. So we've published the literature related to gender differences in systemic sclerosis. This was led by Mike, so he first authored it, and this was agreed up front that I would take the senior author slot on this paper. And when we publish the upcoming qualitative work, I will be the first author and he will take the senior author slot. And it's worth noting that it's really important to negotiate these things up front, particularly because a number of our collaborators are extremely senior consultant rheumatologists and may rightfully feel that they deserve the senior author slot. But both Mike and I were CV building, and it's important for us to have that to gain the senior author publications on our CV. So do make sure you negotiate, and also don't be afraid of profession hierarchies. If you're a health professional or a social sciences researcher, then you're just as deserving as that senior authorship status as the consultant that you're collaborating with. So we moved on to conduct focus groups to look at men's experiences of SSC. We found that there was I conducted the focus groups. I found there was an impact on masculinity in terms, and some of the sort of notable issues around that was sex and intimacy, body image, and loss of masculine roles. There were a number of ways that they coped with their SSC, some of which, like RA, could be destructive. Some of them used cannabis to control their symptoms, which obviously had issues with the condition having lung involvement. And also, like RA, they struggled to open up. Because the condition can have a more severe impact, they tended to not have the option to reject help, so they had to learn to accept it. And this was all underpinned by living with an uncertain future. So I can't touch on all of these, but I'll cover a few of them. So their uncertain future was characterised by the mortality, the worries about their mortality due to the condition. I think about it in terms of what I will or may not be able to do with my daughter. That before I had her, before I got sick, I was like, when I have a child, these are the types of things I want to be able to do with them. And they felt responsible for making sure that their family were able to cope if they were no longer there. I guess I'd have just continued to do the taxes myself, but I figured she better know how to do this. I've involved her a lot more in things like that. They experienced an impact in terms of sex and intimacy. I couldn't even be physical with my wife because the skin covered so much over my penis. It was so tight I couldn't get an erection. I find making love because of my breath. It's the only thing I worry about. It's upsetting. If you said to me, what's the worst thing? Making love. And you worry about the woman thinking, is she okay with this? So it has an impact on their relationships as well. When you can't perform, and it takes its toll. It definitely has a strain on any relationship. So there were a number of issues, including erectile dysfunction, that they experienced because of their condition. Body image was an interesting one. The clinicians that I worked with were really keen for me to find out whether men had body image issues like women do because of the facial involvement of the condition. But all of the men that I asked about this said, no, that doesn't bother us. What bothers us is our loss of muscle mass. I lost everything. I'm 16 stone now. I've no strength, nothing. My muscles are half what they used to be. So they had to learn to accept help and find ways of dealing with that. So they would use humour. I turned in my man card, open this for me. Or bravado of telling other people, you do this, you do that, because my health is the most important thing here. You drill that hole, you climb that ladder. I don't care what you think of me. But it did impact on their masculinity, and it did hurt to have to ask for help. You know how hard it is to have your wife put your shoes, your socks, put your underwear on? That hurt. That really do hurt. And similar to men with RA, these men also struggled to open up. They didn't find that they particularly opened up to friends. They would often only talk to their wife or their doctor. They didn't share. But some of them felt quite protective. They didn't want to burden their wives. So they didn't even always open up to their wives. There are times I feel sick and I want to tell people I'm the breadwinner, so I've got to try and stay positive and focused for as long as I can. My mum and my wife are depending on me. In terms of support, there was mixed views around whether it should be online or in person. Online tended to be driven by the rare nature of the condition. A lot of them didn't live close to their treating hospital, but they did value the interaction and the in-person support. So they were less keen on online information. They still wanted some interaction, even if they did prefer online. And there was limited interest in an app. Again, mixed views on whether it should be all male or mixed gender, but again, when I pushed them on whether they would have opened up as much about their erectile dysfunction in a mixed group, they said probably not. Like RA, they were interested in information or question and answer sessions more than just talking. Many of them mentioned they'd like an information pack. So I will be looking to develop that. And here's some examples of previous men's health leaflets that have been developed in the style of the Haynes Car Manual. So I will aim to look and create something like that. And they would also be keen to include their partners in any support because they wanted them to understand the condition. So, like men with RA, men with SSC reported limited social capital. Due to the rare nature of the condition, patients often didn't live near their specialist centre, and many preferred a support intervention that didn't include travel. But they valued talking, and there was limited appetite for an app or for online information only. It would need to be something interactive. There were some overlap with concerns that RA patients face, such as unpredictable symptoms and their impact on their masculine roles and identity. But men with SSC face issues that may be better discussed with other men who also experience those. So worries about mortality may be, and feeling responsible about what they're leaving behind may be best discussed within other men that also are experiencing that. And also intimacy issues such as erectile dysfunction might be quite uncomfortable to talk to in front of men that aren't experiencing those issues. So there's the potential for a modular approach to support with some common components across the rheumatic diseases and then some tailored to the specific needs or specific conditions. So what can we learn from other men's health interventions about what works? Well, a systematic literature review across long-term conditions for both the qualitative and the quantitative literature, so one literature review for each, found that physical activity, education, and peer support-based interventions have a positive impact on quality of life. There was a need for a clear purpose. Men preferred structured, action-orientated support that met an unmet need. Emotional support occurring as a byproduct of other shared activities and not the purpose of the meeting. They wanted a safe, private, trusted environment. They wanted similar peers, people like them, which gave them a sense of belonging and connectedness. And they wanted to become experts. They were hungry for information, and that enabled them to regain a sense of control and identity. So there's a lot that we can learn there in terms of developing a support intervention, because that aligns very closely with the findings from my work with men with both RA and SSC. So here's an example of an intervention that's worked really well. This was set up first in Australia. It's now been adopted by Age Concern in the UK and many other countries. And it was set up to target social isolation in older men originally. And it's based on the principle that whilst women will support each other face to face, perhaps they'll meet for a coffee and a chat, men support each other when they work side by side. So they support each other when they stand shoulder to shoulder, and this provides a space for them to work side by side and provide shoulder to shoulder support. It's literally men's sheds for them to create, design and build things. In prostate cancer, they developed a photography exhibition to help men express how they're feeling about their condition. They paired them with, I think with prostate cancer, the men took the photos themselves, but there is also from Canada with a suicide project where they paired the men with photographers. And I haven't put any images up of the suicide project because that's something to look at in your own time, just in case anything there triggers you. But if you're interested, do have a look at the link. There's some fantastic images with the stories attached to them, really quite poignant. And then moving on, this was published in The Lancet, the Football Fans in Training programme that created an intervention for obesity. They completely gender sensitised it. It was set in Premier League football clubs in Glasgow. They focused on the science of weight loss. They talked about alcohol rather than focusing too much on diet. And the style of delivery, they encouraged banter to help them talk about sensitive subjects. And they found significant differences in favour of the intervention for weight loss, body fat percentage, blood pressure, better physical activity levels, less consumption of fats, sugars, alcohol, and improved psychological outcomes as well. So in summary, a strong evidence base suggests that men do need their own health strategy. There's a growing evidence base suggesting that men will engage with support if it's practical, structured, provides information, and is held in a trusted environment. There's the potential need to combine conditions to ensure an intervention is viable, but one size may not fit all, so the potential for a modular approach or drop in and drop out as appropriate may work. It's really important to get out of your professional or condition-specific silos and look at what can be learned from other specialties or professional groups. And multidisciplinary team collaboration is really valuable, especially involving patient research partners. But effective relationships does rely on valuing each other's contributions, not accepting profession-based hierarchies, negotiating upfront, and setting ground rules or expectations upfront. So our next steps is to look at a Haynes-style patient information leaflet, so in the style of the Haynes Car Manual for men with systemic sclerosis, and looking at designing and testing an intervention for men with rheumatic diseases. And given we are in the COVID era, it's developing some form of virtual intervention that involves interaction, which enables men to talk and interact, some form of information giving, but that meets the needs of those that aren't wanting to travel. And of course, none of us are wanting to travel at the moment. So thank you for listening.